minute. We're good. So did you go out and celebrate the first day of spring yesterday?
No.
Dancing out in the
Under the
it was supposed to go on.
worm moon.
Well, yeah, it's like, yeah, it was. You know, we had the, yeah, that's kind of a strange.
Super worm moon is what that was called.
Is that W? It's actually
It's
spelled
W-O-R-M,
R-M.
like
Oh, okay.
worm.
I knew they said it was a super moon, and I'm going, yeah, they're all super moons.
All right. I have to look
I
that
don't remember
one up.
having such exotic terms for our moons when I was growing up, but that's okay.
I've asked our media star, Captain Shane Huber, to lead us in the Pledge of Allegiance this morning.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome to the March 21st, 2019 meeting of the Shawnee County Board of Commissioners. My name is Bob Archer. I currently serve as chair of the commission and represent District 3 alongside Commissioner Bill Rippon, who represents District 1, and Commissioner Kevin Cook, who represents District 2. Good morning, everyone.
Good morning.
First item of business, please.
Item 1, proclamations, presentations. Number 1, presentation of annual report by TRIA. Angela Lewis, Human Resources.
Good morning, Commissioners. Angela Lewis with Human Resources. I'd like to introduce Jim Wynn and CJ Rios, who will give us TRIA's annual report.
Good morning, Commissioners. How are you?
Good morning.
It's good to see you guys again.
Thank you.
What I wanted to do today is just kind of give you an overview of TRIA Health, the annual report that we had. As a reminder, TRIA is a benefit that is available to all employees, spouses, and dependents that are on the medical plan. And what our role is we're a pharmacist-based organization, and what we do is we work with members on the medical plan that have chronic conditions who take multiple medications. And what our role is to identify any potential issues, problems, concerns, barriers that are preventing members to be able to get to goal for the medications that they're taking as it relates to the conditions that they have. And if we find any barriers, if we find any potential issues, DTPs, what we call drug therapy problems, we want to identify what those are. We want to resolve those issues not only with the patient, but we want to resolve those with their physicians as well. So what I'd like to do is, this is the condensed report that we have, but share with them what we call success stories. They are stories that we put in here to give you an idea of the types of conversations that our pharmacists have with their patients, the issues that they're having, and the resolutions that we have been able to achieve with those. So with that, what I want to do here, I've got to do this manually. So I have 3 success stories, and so this is the first one where the problems that we identified was, number 1, dosage was too high, duration was too long, unnecessary drug therapy, and duplicate therapy. This is a patient, and just so you know, when we go through this, this is not unusual to have this many conditions for which we're dealing with. This is a patient that had asthma, GERD, high blood pressure, IBS is irritable bowel syndrome, migraines, and menopausal symptoms. The patient had been struggling with GERD, heartburn symptoms, and reported that they were taking Dexilent, esomeprazole, and ranitidine. But what the patient reported to us, and what we could see through the claims, is that these 3 medications are all in the same class, but yet they were prescribed by different physicians. So the physicians did not know that they were on similar types of medications. What they were unaware of, as we talked about, is not only are they in the same class, the PPIs are in the same drug class, they should not be used together. So what we did is we contacted the treating physicians and confirmed with them the issues that they're having. They're taking medications of duplicate therapy, and they should not be taken together for the long-term impact that it potentially can have. And the physicians agreed with that and recommended that we get them off the Dexilent in that regard. As we were having this conversation with the patient also mentioned to us that they had been taking this estradiol menopausal symptom medication since 2000. And as we were looking at this, we were saying that duration is way too long, and the likelihood that the symptoms were no longer present were great. So again, we reached out to the prescribing physician to talk to them about the concerns that we had as far as duration is concerned, and the physician agreed, and we tapered that patient off the medications, and they're no longer taking it. The impact of that is we don't want members on medications that they don't need to be. Number one. Number two is there's a cost associated with those medications, both to the member and to the plan. So the impact and the benefit that we were able to achieve for the plan, for the patient, and for the well-being is that we were able to discontinue 2 of those prescription medications. One of them was costing the plan just about $3,000 a year, $2,886.48 that the plan is no longer going to pay for those medications. And the key is we were able to do this over the phone without the patient having to go back to see their physicians. Again, saving them out-of-pocket cost, saving the plan money in that regard as well. So it's an issue. This individual had 6 conditions. Just so you know, they had 6 conditions, but this individual was taking at the time over 10 prescription medications. So here's the second one that we have here. This is where a dosage is too high, duration again is too long. Diabetes, GERD, high blood pressure, high cholesterol, hyperthyroidism, allergies, and chronic cough. The patient reported that they had a chronic cough secondary to the allergy symptoms, and they went to their physician to get it checked out, and the physician prescribed Symbicort. And they had been taking it for 6 months, but during our consultation with them, the question that we asked on Symbicort is, do you have asthma or do you have COPD? Have you ever been diagnosed with those conditions? And the answer was no, they were not. And so what we know is that Symbicort is not approved for chronic cough. It is approved for those that have asthma and COPD. So what we did is we contacted the physician to, number one, validate, verify whether or not they've ever been diagnosed with asthma and COPD. And the answer was no. So our recommendation back to the physician was let's get them off the Symbicort. Let's treat them over-the-counter medications because we think we can treat it through over-the-counter, or at least let's give that a try. Physician agreed. We took them off the Symbicort, discontinued that medication, got them on the over-the-counter medication with our recommendations. Upon follow-up, their chronic cough had been resolved. Again, this is a discontinuation of a medication, as well as Symbicort. The plan pay is just over $3,500 a year in that regard. So on a medication, unnecessary, no reason to be on it, so we were able to clinically validate that that was the case and then get them off. But again, the follow-up that we do to ensure that the condition is treated and it's controlled, that's the key for us. We just don't, after we have a consultation, we just do not let it go, and but we do the follow-up to ensure that everything is working the way that it should. This is the final one that we have here. This is, again, an unnecessary drug therapy, a duplicate therapy. This is a patient with diabetes, AFib, GERD. The patient was taking glyburide, metformin, Januvia, and Trulicity for diabetes. Again, Trulicity and Januvia are in the same class. They have very similar mechanisms and are not recommended to be used together because there's no benefit to combine them. So again, we outreach to the prescribing physician, let them know what we identified, and talk to them about everything that was going on and whether or not they were at goal with that whole thing, talking about the regimen that they were on. And it was our recommendation, and the physician agreed to get them off Trulicity and continue the other medications. This is a drug that cost over $8,500 a year on a medication that was not medically necessary. So these are just 3 examples of what we were able to uncover with our patients through the pharmacist. Again, the pharmacists kind of act as their primary care physician from the medication side, because when members engage in our program, they're aligned with their own clinical pharmacist, just like they would have a primary care physician. So Our goal, as I mentioned earlier, is to identify any potential issues, barriers, concerns that patients have, to utilize the claims data to ensure that we understand exactly what medications they're filling or not filling, and then utilize that information to bring a care plan together to ensure that the medications and the conditions are as best controlled as possible. And if we do that, then we know that we can have an impact on medical claims cost to the plan as well as to the member. Any questions on those?
How do you find these cases? How do
Right.
they pop up?
Okay, so what we receive RX claims data, and we get that once a month. And we have what we call a trigger mechanism. So through that RX claims, we're looking for members that have one or more of the chronic conditions, taking 4 or more prescription medications.
And do you
And
have
then we do an outreach to them.
Do you have a doctor or pharmacist on board that reviews these?
Yes, we're a pharmacist based there. All of our pharmacists work for us
I see.
in our office, yes.
Okay.
Yeah, thank you. So this is on the annual, oh, I'm sorry, Kevin.
Commissioner Cook.
Well, I was just going to ask, saving the money is great, making sure that we identify duplicate medications is great, but did the employee's health improve as a result of this? Do we have follow-up from the doctors as to whether or not the employee's health was improved?
Right. That's a great question, because what we also do, and again, this is a condensed report, we have what we call HEDIS measurements. So HEDIS measurements tell us, for a diabetic, are they at goal with their A1C? Have they had their foot exam? Have they had their eye exam? All of the things, are they on a statin and so forth? So what we do is we have a checklist of things that we want to ensure. Not every one of our patients are at goal right now, but the good thing is we have our eyes on them, and we understand what the issues are. We have a resolution or a plan in place, and now we just have to see them through that plan. So we have consistent consultations with our patients. It's based on need. If we have somebody that's really out of control, we may talk to them once a month. If we have somebody who is very well controlled, understands the conditions that they have, understands why they have to take the medications, and can afford, there are no barriers, we may talk to them 2 to 3 times a year. But we're seeing them more often than they're seeing their own primary care physician. So we can document through the claims as well as through the follow-ups how they're doing as well as it relates to their conditions.
Sure, thank you.
You're welcome. Any other questions?
No.
So then on the financials, which is a key here, we have 3 buckets that we report on. The county invested $48,346 in just in hard dollar savings alone through discontinuations and moving from high costing medications to lower costing clinically appropriate medications. And I need to stress here, any movement made from moving it from or a change in a prescription, we cannot do it. It has to be done by the prescribing physicians. And we can validate all of these through the claims that we get on a monthly basis. So what we were able to, the impact that we had from a hard dollar savings is we were able to save the plan $66,898, again, through substitutions and discontinuations and switches. And this is just a list of the medications and discontinuations that we were able to do. So we were extremely pleased with that the ROI came hard dollar over 1-to-1, just in hard dollar savings alone. And then what we also report on are what we call healthcare savings. These are the last 2 buckets here. Healthcare savings, and that success story that I talked about earlier where we were able to resolve the issues over the phone with the physician and the member without them having to go see that specialist visit. This is where we give ourselves credit, where we can resolve an issue without those members having to utilize the healthcare services. So in this bucket right here, we had 3 individuals that had previously used the emergency room for the issue that they were dealing with. We were able to identify the problem. We were able to get with their physicians, get it corrected, and we have what we call a 90-day look back. So we go back 90 days after that to see if that patient had to go back to the ER. If they have not, we give ourselves credit for one, because here's what we know. We know if that patient was continuing to have that problem after they went to the ER, the likelihood of them going back is extremely high. And that's with all of these, the urgent care, the primary care visits, specialists, and these numbers right here are what you're actually paying from a medical claims standpoint in that regard. So able to show $23,663 in savings in that bucket as well. And then finally, and Kevin, maybe this is to your point, this is where we can validate that when members come in, this is what we call our compliance. These are members that engaged in our program at the time. You had 10 diabetics that were not at goal. That were not at goal at their A1C, the HEDIS measurements that we're going to go through. We have 10, when they started, were not at goal, today are at goal. So we are able to move them. And again, we can only validate this if they've been at goal for 6 months or longer. So what we do know clinically is that if we can get them on the right path, keep our eyes on them, but we have to have 6 months worth of validation before we can move them from non-compliant to compliant. We had 16 with high blood pressure and 9 with high cholesterol. So I think out of all the buckets, this one's probably the most important, because this tells me right here that 10 of your members with diabetes were at what we term high-risk components of the plan. I can tell you this, if you have a diabetic that goes south, it's going to cost more than $3,756 to treat a diabetic. If you have somebody with high blood pressure who's uncontrolled and they have a heart attack or a stroke, it's going to cost more than $3,908. But how these numbers are brought together is that what they did is they looked at actual ICD-10 codes of medical claim spend, and they looked at compliant members with these conditions versus non-compliant, and on average it cost $3,756 more dollars to the plan a year for a non-compliant diabetic than it does for a compliant diabetic. That's just looking at hundreds of thousands of ICD-10 claims. But I also will tell you that, again, if a diabetic goes south, it's more than $3,756 in that regard. So in total, what we were able to show here is that for the 48,000, sorry, we were able to show $201,971 in savings out of those 3 buckets. Any questions?
Additional questions?
No.
I'd like to recognize and thank our HR department for continuing to look for ways to save money and to look after the health of our employees. I think I'm quoting Angela correctly when she said that saving money is really the icing on the cake, because it is providing health benefit to our employees, and that's the most important part. So thank you. Well done.
Thank you very much.
Thank you for coming this
Thank
morning.
you.
We appreciate it. Next item, please.
Item 2, presentation on county health rankings, Linda Oaks Health Department.
Good morning, Commissioners. Linda Oaks from the Health Department. It's time for our annual presentation on the Robert Wood Johnson's County Health Rankings and Roadmaps Report. We're going to start with hearing from our Health Officer, Dr. John Franco Pizzino, who's also a Senior Fellow at the Kansas Health Institute. They do a lot of work on the data for this. So we're going to start with Dr. Pizzino.
Thank you, Linda. Good morning, Commissioners. Yes, it is a time of the year again when we try to understand how healthy we are as a community. And it used to be a simple question. I mean, in the old simple medical model, people are born, then at some point they become sick, and then they die, and so we measure deaths, we measure how many people have a heart attack, and that's how healthy we are. Things have become a little more complicated because what we have learned in the last several decades of observation and research is that really health care and genetics only account for about 40% of how healthy we are. But 60% of that has roots into our social environmental behavior environment. So what it means is that it's not just what happens in the doctor's office, but it's primarily what happens outside of the doctor's office that will have an impact on how healthy we are as a community. And so Robert Wood Johnson Foundation has been funding for almost 10 years now a project of the University of Wisconsin where they put all this information into this kind of, which I think is a nice model. It looks a little complicated, but it's essentially the same chart that I showed you earlier, turned into a measurable logic model. So what you see at the top is the health outcomes, and that's how long people live and how well they are while they are alive. And then the box in the middle is represents a series of what they call the health factors. So those are the social environmental factors that will in turn lead to the health outcomes that are measured. And those include factors in the domain of health behaviors, clinical care, socioeconomic, and physical environment. What they do, they measure all those elements, and then for each state, they create a ranking of all the counties in the state based on health outcomes and health factors. So in fact, that's why we call it the rankings, plural, because there are actually 2 rankings for each of the counties. A little bit of caution before we start looking at the results. This is not a perfect process. The ranking position itself may change for a variety of reasons. If you think about ranking, it's just measuring ourselves against everyone else. So if the ranking changes, it may be because we have done something different, or it may be because everyone else has done something different, better or worse. There can also be a random error. I mean, all these measures are statistically processed, so sometimes there are statistical issues that may cause an apparent change in ranking position when actually nothing big really happened. And sometimes they change the methodology. They always try to improve their measures, so comparing one year to another occasionally becomes a problem. So that's why what I like here is not just looking at the ranking position per se, but look what I call under the hood, which means let's look at the trend of some of those measures that are behind the ranking. And then we can understand a little better what's driving our ranking position. And finally, there are some issues with data timeliness, even though we call it the 2019 county health rankings. Most of the information is at least a couple of years old. Some of the information may be as much as 7 or 8 years old. So it doesn't really reflect what happened last year. It reflects what happened over a period of several years, but certainly not there recently. So let's start with the ranking then. Our health outcomes, so how sick we are and how young we die, this year slipped from 61 to 79 out of 102 counties that were ranked this year. Some counties are not ranked because there is not enough information for them to be ranked. And so that obviously was a reason of concern for us, and so we looked at the data a little bit more closely. And what we found is that these are the 2 major categories of measures that affects our health outcomes ranking. So the length of life and the quality of life. And the big change in ranking was caused really by the length of life. So that is called something that is called years of potential life loss. And I'm sorry, we need to start with our alphabet soup here. We call it YPLL. Years of potential life loss. And what that does essentially is relatively simple. It assumes that on average people would die at age 75. Some will die younger, some will die later. Those who die before the age of 75 will contribute a number of years to a pool of years of life lost. That is the difference between 75 and the age at which they died. And then they pool all those years, number of years together, and they calculate a rate. So the comparison can be made from county to county, a rate for 100,000 people living in that county, and that's the YPLL. Well, what happened in Kansas is that between 2018 and 2019, our ranking for YPLL slipped from 47 to 78. So essentially, people are dying younger. That's a simple way to put it. I know this is a little small, but just to give you an idea what we are talking about, the red line is Shawnee County, and the dotted green line is Kansas. And you can see that Shawnee County was already higher than the state average, but in the last 3 years, we have seen a progressive increase in years of potential life loss. So once again, that means that over the last 3 years, on average, people have died younger in Shawnee County than they used to before, and then in the rest of the state. We were still not satisfied with that answer, so the question is always, so why? What's causing people to die younger than before. And it turns out that there are two major causes that are driving that. One is homicide and the other is suicide. These are the overall rates of homicide and suicide in Shawnee County. They changed between 2014 and 2017. And you can see that for homicide, we have an increase of 182%. And for suicide overall, we have an increase of about 46%. Even more noticeable is the increase for suicide in the younger age group, 15 to 24. Remember how YPLL works? The younger you die, the more years you contribute to that pool of years of potential life loss. So each and every one of those tragic events of suicide in young people was actually a major contributor to the YPLL pool. To give you a sense of comparison, I don't have on the table, but these increases are about twice as big as the average increase in the state of Kansas for homicide and suicide. So when you translate that into YPLL numbers, the percentage of YPLL increase overall for between 2014 and 17 in Shawnee County was 10%. That's the top row. But for homicide, it was 142% of YPLL increase. And the YPLL due to suicide increased by 69%. So if you take those two together, their contribution to the total YPLL change is 43 and 34% respectively. So overall, 77% of our increase in years of potential life lost was due to an increase in homicide and suicide. That's pretty sober picture, but at least it explains why we saw the relative dramatic change over a period of 3 years. Furthermore, the change is not evenly distributed, and the loss of premature loss of lives are not evenly distributed in our community. If you look at YPLL between 2015 and 17 by race and ethnicity, you can see that for blacks is more than twice as high as that for white and Hispanics. Moving quickly to health factors, remember those are the root causes that we have, the socioeconomic factors. The slip there was not as big, actually between 56 and 59, I wouldn't even consider that a slip. It's kind of rounding error, it's pretty much stable. And that is confirmed by the individual measures, these are only some of them. If you want to look at that, nothing really big changed here negatively. Our violent crime remains higher than the rest of the state and went up a little bit. The good news here is that the high school graduation actually increased substantially from 80% to 86%. But we still have about 15% of our children who live in poverty, despite the fact that unemployment rate has gone down. So people work, more people work, but that's not really decreasing the number of children that live in poverty. And we still have about 1 out of 3 children who live in a single-parent household. When it comes to our behaviors, we are pleased to see that our reduction in smoking rate was sustained between 2018 report and 2019, and we are for the second year in a row below the state average, which was not the case in previous years. Unfortunately, our rate of sexually transmitted infection is still going up and is still higher than the rate for the state. And even though about over 90% of people say that they have easy access to recreational opportunities, exercise opportunities, we still have over a third of our citizens who are obese. So there is clearly a discrepancy there. And I want to mention that 91% is the 4th best number in the state. There is only 3 counties in Kansas where more people than in Shawnee County report having access to exercise opportunities. So that's definitely something good that has been done in the last several years. Clinical care, we remain on the top 4. We were top 4 last year. We are top 5 now, and now again pretty much unchanged. And it's something that needs to be recognized. I mean, clinical care in Shawnee County is top-notch. Unfortunately, once again, that's not sufficient to assure good health of the community. We need more than that. We need to work on poverty, we need to work on homicide, we need to work on suicide, and those kind of problems. And we're working on it. And so I'm going to transition now to Linda, who will tell you just few examples of how the health department is trying to address these and other issues.
Good morning again. So yes, I did want to highlight a few of the measures and some improvements and some things that we are doing. So let's talk about the rough news first, and that's our sexually transmitted infection rate. We know that continues to climb. We're seeing that nationwide, so we're pretty much in sync with everyone in the country. I think this is going to take some real concerted efforts, some big programming changes, and across the board is going to take providers as well as the health department and other partners. So we're going to be taking a hard look at that as we go over the next couple of years. So I want to talk about what I see as some successes have been happening in Shawnee County. So even though our percent of low birth weight is still hurting us in the rankings, you can see we've seen some improvement in this area. And again, that's been a combination of providers with WIC, maternal and child health. We do a lot of work in this area, so we're definitely seeing some improvement in this area. High school graduation rate. Definitely seeing some improvement here. Yay for the economic development that's happening in Momentum 2022. We have the Cradle to Career group that's working on this. I think there's a lot of great work happening in this, and I'm hoping that we continue to go up and at least meet the state rate, if not beat it. So we're getting very close here. Adult smokers. Yes, big success. We're keeping that rate down. I wish I could show you back several more years, but they changed the way they measure it, so we really can't go back prior to 2017, but we were above 21% at one point. So this is a great success. There's a lot of work going on in this area at the health department as well as other places. You can see Tobacco 21. We're going to be talking about tobacco-free parks. We talk about smoke-free multi-unit housing. So lots of great work happening in this area. And then our percent of access to exercise opportunities. So Dr. Zeno did say that. We are fourth in the state, so hooray to Parks and Rec. This is a great accomplishment for Shawnee County, that we can say that 91% of our residents have easy access to exercise opportunities. So again, quality of life, health, it all goes together. So we're doing some great work in this area. So the next step is a save the date. That I have up here. It's about the community conversation around the county health rankings. This will happen April 8th from 11:30 to 1 o'clock at the Topeka and Shawnee County Public Library. We will provide some refreshments. This is the third year we've done this conversation. We're going to be working on the Community Health Improvement Plan. And if you remember a couple of years ago when we had that meeting, we talked about our rankings and what needed to happen. And Marsha Pope is here from the Topeka Community Foundation. That's just one great example, some changes that we've seen. They've really changed their focus. They're doing a lot of work on the social determinants of health and how we can improve health. So I really applaud them for their work they're doing. It just is another example of it takes all of us to make an impact on this. So I hope everyone will come join us on this day and help us continue the conversation and talk about what we can do to continue to improve our health. On April 8th, we're going to be hearing the Kujima report. It's going to be introduced. We won't get to hear the whole report. It's probably pretty long. But this is a report that has come out of last year's conversation. Chris Omni asked some questions about African American Black health and the health outcomes that are suffering, and so they put together a data book with Kansas Health Institute, and they're going to have their report, and it's going to be introduced that day. So I hope everyone will come to hear that also, and they're going to use it as a call to action to help work on some of these health disparities. So, in summary, where we live matters to our health. Health is more than health care, and no one issue can be addressed by one organization alone. We have to all work on this. Promoting that cultural shift takes time, it takes everyone, and of course, progress does take time. So at this point, I'd be happy to stand for questions or have Dr. Pizzino come up and answer any questions you might have about the county health rankings.
You're doing great.
Well, we'll see what the questions are.
Questions for Linda or Dr. Pizzino? No? No? Commissioner Cook?
Dr. Pizzino, can you talk to us about the other counties and what we saw in some of their rankings change, and why Shawnee County changed as much? I mean, do we see that across the board with other counties?
Well, again, if we think about the ranking process, of course, we can't all win, right? We can't all be above average. So since we went down, it means that someone else went up. On average, some of these issues that we have in Shawnee County are common to issues that other urban counties in the state have, especially the higher than average rates of suicide, homicide, etc. Wyandotte County remains to the bottom, but they're doing great work. And I don't know if you had a chance, I share with Linda, I'm sure she'll be happy to share with you if you want to see it. They issued a commentary on their ranking that I think it was absolutely great. It was a very focused. It was an acknowledgement that yes, it's true, we are still 99 or 102nd, but here is what we are doing about it. And we still trust and believe that over a period of time, we will improve. This is going to be a great community and a healthy community. Sedgwick County has not changed very much. Some of the same trends that you see in Shawnee County, you see also in other counties. Sedgwick County actually has a relatively worse ranking for clinical care than Shawnee County has, which somewhat surprised me because they have excellent clinical care institutions there, but they were ranked, I don't remember exactly the number, but lower than Shawnee County. But what really stands out to me that was different in Shawnee County was the huge increase, a relatively huge increase in years potential life lost. And that's not something we have seen in other counties. So as I said, that explains about 75% of why we slip so much in our ranking.
In addressing the years of life lost, I know that you addressed homicide, you addressed suicide. What about other deaths? If we see individuals that maybe lived in Jackson or Jefferson or Wabunsee County, and they needed to come to Topeka for end-of-life care, and they stayed at a hospice for more than 6 months, who would be reportable for that death? Is it Shawnee County, or is it where their home county is?
That depends on how the family reports the death for the death certificate, but to provide statistics for death certificate. So what the project does, the County of Rankings does, they don't collect any new information. They just use information that's available. In this particular case, they look at death certificates. The death certificate has two fields. One is for place of death, and the other is for place of residence. The YPLL is based on place of residence. However, if somebody has been in long-term care in, say, Shawnee County for an extended period of time, and the family considers that the place of residence for that particular citizen, that's what's going to be listed. But somebody will come here for acute care and dies in Shawnee, say a trauma center in Shawnee County. The place of residence will not be Shawnee County. It will be wherever the person who deceased was a resident. So, yeah, there may be a little bit of that. I think, honestly, in the grand scheme of things, I don't think that really has a big impact. And again, remember, 75% of our change is accounted for by homicide and suicide.
Along that same line, if we have a person who is a transient lifestyle or impoverished lifestyle, and they commit suicide in Shawnee County, does Shawnee County get tagged with the suicide because that's where it occurred, as opposed to this may be not really where they're from?
Well, if the person had no stable place to live, yes, that's probably correct. I suspect that somebody wouldn't move from one country, someone who is homeless wouldn't move from one country to another just to commit suicide. So my guess is that many of those people, first of all, I think the number is probably relatively small, but most of those people, for all practical purposes, are Shawnee County citizens and residents. They just don't have a permanent address on file.
And then finally, suicide relates to mental health. 4 years ago, Shawnee County really took to heart these rankings and tried to turn the tide, and in fact we've made it worse than better, and so we continue to go down and not up. Is this a call to action to double down on mental health funding?
I think the mental health issue is huge. I'm not in a position to tell you how much funding you ought to allocate to that. More money is always welcome, of course, but that's really not my job. I can tell you my experience, not just in Shawnee County, but throughout the state, every time we do what we call a community health assessment, which means we look at the data and talk to the community and ask them what's the problem here for health in your county. Behavioral health and mental health always comes to the top.
I mean,
always does.
This commission has been, I mean, with the exception of Commissioner Rippon, you're the new kid on the block, but Commissioner Archer and I have been very committed to mental health and putting more and more resources into mental health, but we haven't seen the impact of that yet. How long does it take to see an impact?
For mental health, as well for everything else, it's at least years, if not decades. I can tell you my professional opinion based not just on what I do as a health officer, what I see and observe, and the conversation I have with colleagues. The need for mental health support in this county is not sufficient. I mean, the needs are bigger than the resources that are available to meet those needs. Unfortunately, that's not unique to Shawnee County, so I'm not saying that to reflect bad light on Shawnee County, but it's the sad reality. The needs are increasing exponentially, and you know, people are writing books about that. Why do we have so much more mental health in this country, not just in Shawnee County? and the system cannot keep up with that. How long is it going to take to reverse that? I wish I could tell you, but it certainly is going to stay with us, I think, for several years.
All right. Thank you.
Thank you. All right. Thank you, Doctor.
Thank you so much.
Thank you, Dr. Pizzino, for being here this morning. Thank you, Linda. Next item, please.
Item 3, consent agenda.
4 items on the consent agenda. Any questions or comments?
Move to approve as presented.
Second.
Motion made to approve the consent agenda by Commissioner Cook, seconded by Commissioner Rippon. All in favor say aye. Opposed, no. Motion carries 3-0. Next item, please.
Item 4, new business A, County Clerk number 1, consider all voucher payments.
Under Sheriff, Davis Moore Automotive Incorporated, total $334,772.80 is for 10 Dodge Durangos. Under Solid Waste Recycling, Armor Equipment totaling $202,905.35 is for a side loader refuge truck minus trade-in. As of March 20th, 2019, total vouchers $1,055,205.59. And I would move that we approve the vouchers.
Second.
Motion made to approve the vouchers by Commissioner Rippon, seconded by Commissioner Cook. All in favor say aye. Opposed, no. Motion carries 3-0. Next item, please.
Item A2, consider correction orders.
I'll move to approve the correction orders.
Second.
Motion made to approve by Commissioner Archer, seconded by Commissioner Rippon. All in favor say aye. Opposed say no. Motion carries 3-0. Next item, please.
Item B, Public Works Solid Waste number 1, consider approval of a revised project budget in an amount of $413,000 for design and construction of a replacement of a county culvert with a bridge on Northwest Bailey Road over Snake Creek.
Good morning, Commissioners. Tom Flanagan, Public Works. The original budget that was submitted for this project was submitted to you folks and approved in January of 2017. At that time, we had minimal amounts of engineering available to study the project, determine the full scope of the project. So we're back now. We need to adjust that budget to increase the construction line item. All the other items, line items of the budget went down, and got a little drawing here to give you an idea of what we're talking about. This right here is Bailey Road coming through here, and we have a box structure right now that's in poor condition. We're going to replace that 17-foot wide by 7-foot tall box with a double 14 by 10 reinforced concrete box to be able to handle the drainage on Snake Creek through here, because we have a persistent flooding problem in this general area here, which is washing out our road, and it washes out this resident's driveway constantly. So we're up there fixing it all the time. To do that, to increase the size of this box, that increased the construction cost. But then we came over here and we armor plated this side of Snake Creek so the flow on Snake Creek as it's moving down through the box doesn't continue to migrate towards the road, overtop the road, and then wash the road out. So that's the reason why we've got the increased cost for construction. This project will be funded by our Public Works Spatial Bridge Account 202. I'd be happy to answer any questions you might have.
Questions for Tom?
Move for approval.
Second.
Motion made to approve the revised project budget by Commissioner Cook, seconded by Commissioner Rippon. All in favor say aye. Opposed, no. Motion carries 3-0. Next item, please.
Item B2, consider awarding the bid for replacement of the culvert on Northwest Bailey Road over Snake River with a new bridge to Claver Construction Company, Inc. at a cost of $328,657.64, with funding from the Special Bridge Fund and authorization and execution of contract C-132-2019 for same.
Tom Flanagan, Public Works. This ties to the previous item. Bids were received. We received 3 bids for the project on February 26th. Claver Construction, as the county clerk read, was low. We recommend the contract be awarded to Claver. We've used them many times before. They do great work, so we have no problems with that. We would recommend the award, and then, again, funding is per the special bridge account.
Questions for Tom? I'll move to approve awarding the bid.
Second.
Motion made to approve by Commissioner Archer, seconded by Commissioner Rippon. All in favor say aye. Opposed, no. Motion carries 3-0. Next item, please.
Item B3, consider approval of request to exchange federal funds for state funds in an amount of $951,587.03.
Tom Flanagan, Public Works again. KDOT announced they're making federal funds available to Shawnee County again this year, and we can either apply those federal dollars towards a federal aid developed project. That means KDOT's going to get involved. It lengthens the time. It actually costs us more money, or we can exchange those federal dollars for state dollars on an exchange rate of 90-10, and then we can apply that money to any project we want to apply to. So if we exchange the $951,587 for state dollars, we will get $856,428, and it's our intention, if you approve us to exchange those dollars, we'll take those dollars and apply them to Southeast 29th Street project that's ongoing right now. I might give you a little historical background on this. Seems like our federal obligation is dropping. 2015, we received $1.29 million. 2016, it bumped up to $1.3 million. 17, it dropped to $1.1 million. 18 to $1 million. And at that time, last year, that's when the state changed the exchange rate to 75.25. So out of the $1 million, we only netted $750,000 available to us to exchange. Then the exchange rate was restored back to 90-10, and if you take the $951,000 we've got now, exchange them 90-10, we get $856. So we have a net gain over last year's funds.
Of 100,000 plus.
100,000, yes.
Okay.
Happy to answer any questions.
Any questions for Tom? Yes, Commissioner Cook.
You indicated that you were going to apply this to the 29th Street that is ongoing. What is the status of that project? Is it progressing on time and on schedule, or?
Commissioner, we were falling behind due to the bad weather, due to the utilities that were in there. We have got the utility conflicts basically solved, except for now we're running into a conflict with a city water project that was been working all last year. I think it's being managed. We met with the city. They're working with their contractor to get those people out of our way. Now that the weather's clearing up, We're starting to make better progress on the bridge. The precast structure that we're going to put in is due to come in April the 3rd, so we'll start installing that April 3rd. So we're approximately 2.5 weeks behind on setting that bridge structure. But the contractor, Bettis, they're doing a great job. They're moving. Those guys have worked in some of the most horrific weather you can imagine, and they work Saturdays and Sundays to stay on schedule.
Thank you, Tom. I was just wanting to look forward as our cost estimates if this is something that, ultimately you don't know where it's going to wind up, but if we anticipate the cost going up or down as we look at applying these federal funds, or if we're staying within budget at this point.
Yes, sir, we are.
All right.
Yes, sir, we are.
Additional questions? Motion?
I move that we approve.
Second.
Motion made to approve the request by Commissioner Rippon, seconded by Commissioner Cook. All in favor say aye. Opposed, no. Motion carries 3-0. Thank you, Tom.
Thank you, Commissioners.
Next item, please.
Item C, corrections. Number 1, consider authorization and execution of contract C-133-2019 with Washburn University to offer internships, externships for Washburn University students at the Department of Corrections.
Good morning, Commissioners. Brian Cole, Shawnee County Department of Corrections. This is just kind of to formalize the process and working with our partners at Washburn University that we provide a long history of providing internships and externships with the law school and the graduate schools and undergraduate programs. We do this all the time, but in speaking with their staff, they just asked to formalize a little bit, and this was at their request, which I did go through the county counselor's office for approval, and they looked at it for legality and form. So there is no money attached, but this just enhances our relationship with Washburn University, and just be happy to answer any questions you may have.
Very good. Are there questions for Mr. Cole this morning?
I approve. All right. I move that we approve.
Second.
Motion made to approve by Commissioner Rippon, seconded by Commissioner Cook. All in favor say aye. Opposed, no. Motion carries 3-0. Thank you, Brian. Next item, please.
Item 5, administrative communications.
This is an opportunity for any department head or member of the community to address the commission.
Good morning, Commissioners. Kellen Seitz, Inspector of Venue Management in the Kansas Expo Center. Wanted to update you on some events going on this weekend. We have loaded multiple loads of dirt back into the facility for Demo Derby this weekend. So that kicks off at the facility tomorrow night. So it's loud. Bring earmuffs if you're coming. But come out and enjoy some power sports activity with us. It should be a warm weekend, minus the rain. Last week we did finish up, or last weekend, excuse me, we did finish up a great event in partnership with Visit Topeka and the Greater Topeka Partnership with Kansas Kids Wrestling. Happy to report that that was one of the higher attended years in recent history. So still working up our financials and settlement of that event. So once we finish that up, I'll give you a more detailed report there. But and then also, if you're looking for ready access to any workout facilities, there is a ton of stairs in front of the building, and you're welcome to, if you're in Central Topeka, come out and run those if you need access to any of that. Well, I'll go with you. Thank you.
Thank you, Kellen. Thank you.
Good morning, Commissioners. Aaron Mahan, Shawnee County Emergency Management. I just want to let you know that on the first part of March, we finished up a series of exercises with the Auburn-Washburn School District. We began with some tabletop exercises, then they had a full scale at one of their middle schools, and then finished up with a tabletop exercise just this past Tuesday. We were also invited to the board meeting for that school district on Monday evening, along with other first responders that were involved in our exercises. We worked with the Sheriff's Office, the Police Department, High Patrol, and several of our local and rural fire departments in order to prepare for certain incidents at our school districts, and I think it came out very well.
Thank you, Aaron. Anyone else this morning? Commissioner Cook?
No, nothing today.
Commissioner Rippon?
Well, I had the opportunity to go to Shawnee Heights Elementary and work with it's Mrs. Soba's gifted class. And as a class project for this semester, they're doing a master plan of Gage Park. And so that's been interesting. I've been working with Jim Martin. He's been working with the class. And I had the opportunity to go do my history presentation for them and review how they're coming along with their project. But it was just a fun day, and the kids are doing remarkable work. So I was very impressed. So that was it.
That's excellent. I can tell you're enjoying yourself, Commissioner Rippon. And all these assignments myself, I would have felt out of place in a gifted class, but not you, obviously. Next item, please.
Item 6, executive session.
There is a need, and bear with me here. I will make a motion to go into executive session for 30 minutes. Number one, for consultation with an attorney for the public body or agency which would be deemed privileged in the attorney-client relationship to discuss the planning department. 2, for consultation with an attorney for the public body or agency which would be deemed privileged in the attorney-client relationship to discuss the organization and mission of the emergency management department. 3, for consultation with an attorney for the public body or agency which would be deemed privileged in the attorney-client relationship to discuss sewer districts. Number 4, to discuss personnel matters of non-elected personnel, specifically to discuss the wages of non-elected personnel. And finally, to discuss personnel matters of non-elected personnel, specifically to discuss performance of non-elected personnel. That's a motion, and no action is expected to be taken. That's a motion.
Oh, I'll second.
Motion made by Commissioner Archer, seconded by Commissioner Rippon. All in favor say aye. Opposed, no. Motion carries 3-0. We're in executive session.
Were you worried there for a second?
No, you're not going to say that about that one?
Ready? We are back from executive session. No action is required, and we're officially adjourned. Have a good weekend, everyone.
It's just for